everyone. Susan, can you hear me?
Yes, Charles, I can hear you. Can you hear me?
Great. Yeah, I can, and everyone can hear us. So good afternoon or good morning, everyone, depending on where you are. We're going to start in about 1 minute, and as you can see, we are having our screen ready here. Susan, just to make sure, would you mind trying? Can you click the screen to see if you can control the slides?
I'm going to hit the down button and see what happens, okay?
Yeah, yeah.
No, didn't work. Let me try.
Why don't you press with your mouse on the screen and then press down.
Okay. No, but I can have you advance.
Yeah.
That's fine.
Let's do that. Okay, so let's get started. Okay, so again, good afternoon, everyone, or good morning for some of you. Thank you very much for joining us. My name is Charles. I'm the CEO and co-founder of Link Senior, and today we are hosting our monthly Link Senior webinar. Today we are focused on the rules of participation and resident engagement. So some perspective, as most of you will know today, we are 6 months in under these new regulations, and we're excited to have Dr. Susan Levy give us an update and discuss a little bit what the impact is on resident engagement. Before we get started, a few housekeeping details. One, the handout for today's presentation can be found in the GoToMeeting or GoToWebinar box in your screen. Just look into handouts, and we've provided you with a PDF so you can keep it for yourself or obviously share with your team. The second handout item is, housekeeping item is that you have all been placed on mute because of the large number of attendees. But if you have any question during the presentation, please feel free to use the chat function, and we will select a few to be answered at the end with our Q&A section. Also, the recording of this webinar will be made available so you can re-listen to it if you wish at another time or share with your team. And last but not least, CEUs are available through NAB and NCCAP. In order for you to receive your CEU, at the end of this presentation, we will put in the chat box the link to the survey so we can have your information and then send you the CEUs, and that will be done on Monday 25th, next Monday. You will also receive a survey that will pop up, so you can have it in two different ways. One is the chat, or it will just pop on your screen at the end of this webinar. Something very important is we cannot provide CEUs without having you fill out the survey, and if there are multiple people, as it happens often, multiple people at the same location with the same screen, each person needs to fill in the survey themselves. And again, that survey will be provided in the chat box, or if you have any questions, feel free to email us. So with that, let's get started. Again, the webinar topic today is rules of participation and resident engagement. The agenda for today is we are going to review the speakers, and we're going to have Dr. Susan Levy review the regulatory changes in the past 6 months under the new rules of participation. I myself will provide a little bit of insight in terms of current and future state of resident engagement. And then Dr. Levy and I will discuss in section number 4 the best practices and advice under these new rules. And at the end, we will try to have about 3 to 5 minutes for Q&A. So again, if you have any questions, feel free to ask them in the box section in the box section of the chat of the GoToMeeting. So with that, I have a great pleasure to introduce to you Dr. Susan Levy. She is a board certified in internal medicine, in geriatric medicine and hospice and palliative care. She has been a medical doctor for over 25 years and a certified medical doctor, CMD, since 1996. She is the past president of AMDA, the Society for Post-Acute and Long-Term Care Medicine. She's also, on a side note, but very important note, passionate about resident engagement and has been great at helping us and the overall market understanding the importance of not only person-centered care, but how person-centered care can be delivered with activities, life enrichment, and again, resident engagement. I myself, again, I'm Charles Vilmeren, CEO of Link Senior. Long story short, I kind of fell by accident in this industry, in the senior care industry. Started a company where we are now one of the leading engagement platform, resident engagement platform for senior care. That was about a little more than 10 years ago, actually. And obviously, in the process, fell in love with the residents, how we engage them, and how we improve quality of life through meaningful person-centered care. So with that, let's get into the session description. Broadly speaking, we know that the regulations provide a lot of changes in how we work, operate, and so on and so on. So I'm going to now leave it up to Dr. Susan Levy to report and give us a little bit of indication about what it is now that we're 6 months in. Dr. Levy, your show.
Okay, thank you. So anyway, we're going to be talking a little bit about the regulatory changes, and it's a pleasure to be with you. And Charles is going to help me advance the slides, so hopefully we'll stay in sync for you. But certainly over many years of change, many of the things that we've seen is in our industry is that assisted living has really changed in the scope of services it provides. We've had a lot of focus on aging in place. Alzheimer's and memory care have become common words for all of us when we talk about post-acute and long-term care. And certainly we're dealing with changing demographics. We can't go anywhere without hearing about the baby boomers in our country, and the numbers of patients who are now every day reaching the age of over 65 certainly is increasing. So next slide. So one of the things that we know that's really has come into our industry is this whole concept a little bit about culture change, patient-centered, person-centered care, and a new language that we're using in how we approach and speak with our residents and patients in post-acute and long-term care. So culture change really brought us to a new way of thinking about how we might be able to really put patients first and really focus on this whole concept that is really part of that, or an extension of that is really person-centered care. So, and with that, we certainly have a new language. We think differently. We try to write care plans in person-centered language. So there's a lot that we're doing very differently. So next slide. So, just kind of going over the rules of participation, and I'm not going to read all this for you. You can, but certainly there was the, if you will, the old language that basically was in prior regulations. But as of the new regulations that clearly went into effect in November of 2017, we really see a much more bigger focus on the importance of evaluating patient preferences, giving residents choice. Looking at individualization, trying to focus on people's independence, and really trying to even keep them engaged with their community. So the next slide. So one of the things that's been happening in the background also of the new regulatory changes is that, as pretty much everybody knows today, today is that in 2012, as a result of a number of different things that have occurred in the information that we were learning, is that CMS launched the Partnership to Improve Dementia Care in their efforts to recognize that it seemed like we needed to do a much better job in our post-acute and long-term care settings. And in their case, since they primarily regulate nursing homes, to really look at how nursing homes in this country could provide better dementia care. And one of the markers of that was also being concerned about what seemed to be an increasing focus on the use of medications, particularly antipsychotic medications, and for patients who are with dementia, and really looking to see if we needed to address that. And so the partnership was launched in 2012. Next slide. Basic goals of the partnership. Really, although everyone's focused on the medication use, that's part of it. But the real focus of this initiative was to really provide the best care and quality of life for our residents who suffer from various forms of dementia. Certainly, reducing the use of medications that weren't necessary has always been important to all of us who are in geriatrics, and certainly those who are regulating nursing home settings. And to really look at this whole concept of trying to use non-pharmacologic alternatives, which frankly are just good practice in general for geriatric care. Next slide. So why now? We talked about the demographic change. We have an aging population that's growing by day. We know that this is a disease that's highly prevalent. And in fact, if we talk about our nursing homes, it's probably the most prevalent disease of this level of significance that we have in our nursing homes that we're trying to manage. We also began to learn that the medications that we were using probably weren't as safe as we thought that they were. And so that we had a shift in the risk-benefit ratio of using antipsychotic medication for attempting to manage behaviors, and often with very little effectiveness. We had reports from the Office of the Inspector General that reported about the overuse of medications. There were congressional hearings. The consumer advocates were concerned about essentially overusing medications that weren't indicated, and also the increased focus on cost effectiveness. If the medications aren't that effective, they're not inexpensive, and are needing to look at the value for management in our healthcare setting. So next slide. Okay, and these are just, we can run through these probably next a couple slides pretty quickly, but we're really talking about recommendations that have occurred in various reports, because although there was a lot of focus on nursing home care, there was a more recent report that came out from the GAO that recommended, this isn't just about nursing homes, that in terms of the use of medications that often may be inappropriate, this extends to other settings, both assisted living and the community setting. And that probably in our National Alzheimer's Plan, these issues in management of dementia in these settings also needed to be included and addressed. So the next slide. And so what's some of the other focus? If you haven't heard of a program called Choosing Wisely, you should, because it's been an effort from the American Board of Internal Medicine to really work with other professional organizations to have them help identify areas where there are these maybe myths of treatment. And so organizations over time have come up with these series of 5 recommendations from on various topics regarding things that should or should not be occurring, which are good practice based on current evidence that we have. And certainly AMDA on this side, which is an organization that's very near and dear to my heart, in their first round of Choosing Wisely, really did focus on not using any psychotic medications for the behavioral and psychological symptoms of dementia without assessment for the underlying cause of behavior, and then certainly also trying to try non-pharmacologic interventions. And I think on the next slide, we see this was also confirmed by the American Geriatric Society, a similar society, which is on the next slide. So let's have the next slide, and we'll move forward. So additional guidelines and additional organizations are also weighing in on this. And this is from the American Psychiatric Association, again, a reference for you back in May of 2016, looking at what the appropriate use of antipsychotic medications in patients with dementia are. There's no expectation that this is going to go to zero, but we want to really focus on the appropriate use and only using these medications in the dose necessary for the period of time required for indications that's appropriate. So next slide. So PTSD, I've used this term, and what we're talking about are the behavioral and psychological symptoms of dementia. And the behavior symptoms are the things that we often talk about, which is the aggression, the screaming, the restlessness, that wandering, and actually the agitation that we see. The psychological symptoms that we talk about, and frequently are symptoms that can respond to medications, are the anxiety, the depression, and then basically the psychotic features, the hallucinations and delusions that individuals suffering from dementia may have in various portions of their illness. So next slide. And we know that over the course of Alzheimer's disease, that we see early on the focus on the memory problems we're seeing, but then we begin to see more problems with functional decline and the behavioral problems as the course progresses. And ultimately, as we know, this is a terminal disease that progresses over years, can be more rapid in some individuals than others, but it has an unrelenting course. Next slide. So when we talk about the behavioral and psychological symptoms of dementia, what we do know is that as the disease tends to progress, we see these more often. Those that occur, they can wax and wane and occur during different periods of the illness. But we do know that individuals who seem to experience wandering and those that have agitation do seem to be enduring features. Next slide. I also think it's very important when we talk about some of these behaviors that we look at and really make sure we differentiate agitation from aggression, because aggression is really what concerns us about the possible risk to others, where the individual really is engaged in either resident-to-resident altercations or resident-to-staff altercations. Next slide. So what happens? This is often the reason that individuals get institutionalized who have either in nursing homes or assisted living who suffer from dementia, because the behaviors reach a point where their families can no longer manage them in the community. We also know that in facilities that these can create staff turnover and burnout. And certainly, particularly with our advocating consistent assignments, that can sometimes be difficult for some of our staff when residents are indeed not just agitated, but also can be aggressive. We know that in terms of the course of the disease, that people who do have more serious behaviors they tend to have a worse prognosis and tend to decline more rapidly. This is costly to healthcare, and often these results in hospitalizations in emergency rooms, which may or may not be avoidable. Next slide. So what are some of the things that medications will work for and won't work for? Well, I think I already mentioned the wills a little bit. We'll see that again on the next slide. But these are the list of some of the unresponsive symptoms. These are things where actually medicating typically is not going to be effective. So in reality, you may be giving a medication for these symptoms that's going to have no effect and may actually have harm. Next slide. So those symptoms that do tend to respond are if you will, the delusions and hallucinations. And remember, not all delusions and hallucinations need to be treated. It's those that are maybe persistent, distressing, interfering with care in a more serious way. If someone's losing weight and not eating because they think their food is poisoned, that indeed is probably a delusion that may certainly warrant more aggressive intervention and medication. So some of these symptoms that are listed here are the ones that, if they become problematic, interfere with care, or causing harm to self or others, certainly may respond to medication. So next slide. So how do we approach patients? And this is basically the standard approach medically, if you will. The appropriate care process is recognizing that that's what we're dealing with, assessing for cause, in other words, going through a differential diagnosis. Why are we seeing this? Looking at treatments, but in these cases, unless there's a serious threat to self or others, looking at non-pharmacologic interventions prior to using medication. And then obviously monitoring, so seeing how the patient, the resident, progresses over time. Are they responding to therapies? And then adjusting that therapeutic regimen. I think that's where facilities sometimes have difficulty, is too many people just get the attitude of, well, we don't want to rock the boat, things are stable now. But the residents change over time, and we need to recognize that we need to adjust their management plans over time, both as they change and when they're in various phases of their illness. Next slide. This is actually recently a ARC study that was published within, I believe, the last couple of years. So it's I always say our tactics at work. that really looked at some of the various non-pharmacologic interventions, though, for agitation and aggression and dementia. So you're asking me to use these, but what's the proof that they do anything? So next slide. And unfortunately, as you look at this, and I don't want to go into too many details, except for a couple of these interventions, there's not a lot of good, if you will, evidence-based literature that supports their use. We do have limited articles and research that's been done on areas like music and aromatherapy. Primarily, the reason is that it is very difficult to do these studies, and that, you know, what you're doing with the study is that you're only looking at one intervention, and we have beliefs that in every individual it may be different types or combinations of interventions that really may be effective. So clearly what the ARC study demonstrated, the ARC, if you will, review of the literature, is the need for to do more research to really be able to understand what of our interventions really are effective. Next slide. This is also a similar reference for you that's been out, was even a little bit older, but also was a big study done by the VA that really was a good review and overview of non-pharmacologic interventions, so another good resource for you. Next slide. So talk a little bit back to the Partnership to Improve Dementia Care. So the initial goals and then subsequent goals, because I've kind of called it phase 1 and 2, and we're now in phase 3. But at the end of phase 2, there really was a goal to reduce by 30% by the end of 2016 the use of antipsychotics. And the partnership, during the partnership, again, we had the quality measure come in for short and long stay residents. But the focus was on the 30% reduction in long stay residents, which actually was met, and it's continuing to decline even as we look at reports that come in from CMS. Other initiatives that have also occurred that may be seen certainly are the dementia focus surveys that also were developed as part of the work that was done on the Partnership to Improve Dementia Care. So, okay, so I think next slide here. Again, just to kind of show you the graph, and I think there's actually some more recent studies, but we've really by the first quarter of 2016, we had reached that, certainly had reached the goal that was set. So next slide. So now we're in what I call phase 3, which is the late adopter phase, recognizing that we really have done a very good job in the majority of facilities in decreasing the use of medication and changing how we're managing residents with dementia. But what CMS recognized, and many of us have seen, is that there were some facilities who really just didn't seem to be able to get on board, if you will, for a variety of reasons. So the focus during this phase is to really look at those what we're terming late adopters. And those are facilities that either had no decline or actually an increase in their use of antipsychotics over the time of that the partnership had been in effect, from the baseline period at the end of 2011 as the data to when this phase 3, if you will, started. And the goal is to work with those facilities through often their state coalitions and probably providing them some additional resources to see if they can achieve a 15% reduction by the end of 2019. And also a goal to try to see if we can learn from these facilities what their obstacles to implementing change in their facilities has been, so that we can better understand and help other facilities maintain the success that they've had. Next slide. Okay. So now we're into the regulations for antipsychotic use in long-term care. And I think the biggest summary here is to say what I always tell people is read the regulations. Certainly in the regulations and the interpretive guidance with them really does kind of explain what your medication approach to these patients and residents certainly in your nursing home should be. And these are actually also good guidelines really for assisted living to use, and anyone who's caring for residents who are also utilizing this medication. Next slide. Okay. So what are some of the things that we've seen in the revision of the long-term care rules of participation? I think everybody knows about the different phases, 1, 2, and 3. We're currently in 3. We're currently in 2. 3's around the corner. The focus on QAPI and having a QAPI plan, quality assurance and performance improvement. and really making sure that you are working on your project, but also have incorporated these principles into your QA and A meetings, and that you're moving forward with this. From a medical director perspective, one of the changes was the requirement that I get the drug regimen review reports, which is really important. A big part of what people do in this setting is prescribe medications. It's important that the medical director, whether they're caring for the residents or they're just in the medical director role, certainly get some idea of what some of the concerns are about medication prescribing in the facility. I'll focus on competency-based staffing. The drug regimen review that we've alluded to before, actually statements in there that does require chart reviews in specific circumstances. But the real key in all of this is a real strong focus on patient-centered care by all disciplines. Next slide. So what are some of the things related to the medications that we've specifically talked about is that certainly they've expanded the definition of psychotropic drugs, and really trying to recognize that it's not just about antipsychotics, but it's all psychoactive drugs that we need to be really sensitive to. There's also the regulations around the use of PRN psychotropic drugs to be time limited, and certainly in the case of antipsychotics, the requirement for face-to-face assessments if those medications are continued. And certainly the other issue is better documentation in the medical record of responses to drug regimen reviews, explaining rationale for not implementing. Just physicians and practitioners can't just check off, okay, we're not going to do it. They actually have to give an explanation either on the consult or request form or in their progress note. Next. So I'm a practitioner and a medical director. So what should our role as a practitioner be in dementia care? So, you've got the medical director, you've got the attending, which today is sometimes you have physicians that are certainly required to still care for residents and oversee the care of residents in nursing homes. But more and more nurse practitioners and physician assistants are now doing as many as 40% of visits in this in the nursing home setting. And similarly, we're seeing more and more visits by individuals, certainly in assisted living. And then we also have our mental health providers, that many facilities have contracts or agreements with various groups to bring mental health expertise into the facility. So what are their various roles? Next slide. So as a medical director, you should be an educational resource. You're responsible for quality oversight. It's a big chunk of your job, as is written in regulations. It's important that you communicate and provide feedback to the various providers and practitioners that are working in the facility regarding their performance and how they can improve their performance, and keeping them abreast of what's happening in the facility from a quality perspective. What are some of the various initiatives, and certainly keeping them abreast of what regulatory changes may affect them. Also, the importance that medical directors need to be speaking and communicating with these mental health provider groups, both the individual that serves them as well as maybe for some of these larger groups in their corporate structure, but really needing to make sure that there is a collaborative approach. We don't just separate mental health from the medical issues, that really requires collaboration. They should be a clinical champion. If you're having behavior rounds, they should attend. They should review cases when asked to. They should really be helping you in the facility. And they should have a leadership role and lead by example and support non-pharmacologic intervention. Next slide. So your practitioners, who may or may not also be the medical director, really are obligated. The expectation is they accurately diagnose dementia, what type of dementia, as well as other mental health disorders that may or may not be present as comorbidities. That they are supportive of the staff, and that they also buy into non-pharmacologic interventions for residents with PTSD. And certainly that they prescribe these medications, all psychoactive medications, judiciously. They should prescribe all medications judiciously. That they get help with diagnosis and treatment if they need it. That they do review drug regimens regularly, respond to pharmacy concerns, and initiate GERs in the appropriate time frame. They should help assess patients timely when a behavioral concern is identified by staff, and they need to work with the team and use the team as a resource to help us all have better patient outcomes. Next slide. And our mental health providers, again, they need to respond timely. They need to do a thorough job, assess, accurately diagnose, not give me 10 different ICD-10 codes for the patient, but give me what indeed they believe is the condition and keep those current. They should be supportive of non-pharmacologic interventions. They should help with staff education. They should collaborate with the, if you will, the medical team, because they're part of that team, and work with the medical director, facility staff, attending physicians, nurse practitioners in the facility in a collaborative manner. And also be communicating with families and residents. Next slide. And our mental health providers. We covered that. Here we are. So, switch a little bit back to this whole concept of, what is resident-centered care? And I think, these are some of the principles of that I think are important for us to recognize. The importance of personhood, who we are, and who each person in our facility is, knowing that person. And that's sometimes one of the saddest things I see is that we know someone's been in our building for a long time, but we really don't know a lot about them and how they got to the status. We maybe know their medical conditions. We have a list of diagnoses, but do we really know who that person has been? And without that, when we talk about non-pharmacologic interventions, when we talk about all these things we need to do, we're not going to be successful. Certainly the regulation support and the right thing to do is to give people as much choice as you can, and some autonomy in decisions when you're able to do that. Certainly focusing that none of this is done at the expense of quality care. And the importance of building nurturing relationships. And we all see that in our facilities, where sometimes really the staff in some cases becomes the family, or becomes the extended family for the individual who we're caring for. And certainly that we create a supportive physical and organizational environment that helps support resident-centered care. And that means leadership has to buy into the importance of this. And also that as we think about changes in our physical plans, we need to think about what's the right thing to do for our residents. Next slide. And so this is actually an article that I've just put up as a reference that was published not that long ago in JAMDA, which really does demonstrate some evidence based on some customer service surveys that implementing some of these principles of person-centered care does actually improve some resident satisfaction with nursing home quality. Next slide. I'm not going to go into details of this, but it really was, this study was actually done out in the Midwest and really looked at ways to really bring in education and training to each facility based on some grant support money, and then found these positive results afterwards. Next slide. So I'm also plugging AMDA, the organization that's near and dear to my heart a little bit, in the sense of some of the things that we've done as an organization, and actually did several years ago when we redid our, if you will, tasks and functions of a medical director in post-acute and long-term care. We added a function. We'd had this document around for many years, but we added the function of what their role is for patient-directed care. And the way this works is that we identify functions and tasks, and the Tier 1 tasks are those that are definitely required. The Tier 2 tasks, which are on the next slide, are less so required. But again, the focus that even as a medical director, the importance of supporting with the staff, with everything that we do, a patient-centered focus and allow for patient-directed care as much as possible. Next slide. And these are some additional, if you will, say maybe not required tasks, but recommended tasks that would be included as part of that resident-directed care and patient-centered care. To make sure that all the policies and procedures, as we review them, are really written in that language and really are focused on putting the residents at the center of what we do. Next slide.
Well, thank you so much, Dr. Levy, for leading such an interesting update. A lot of information, and obviously one would ask, well, what is the role of resident engagement. And I think that Dr. Levy mentioned quite a few things where we as engagement professionals can actually work as a team and improve. And I think it's an interesting time where there's a lot of focus on some of the things that Dr. Levy mentioned in terms of regulation, the overuse of drugs such as antipsychotics, and all of these provide huge opportunities for us, again, engagement professionals, to be active in increasing the quality of life of the residents, of our residents placed under our care. I think that to look at the state and current and future of resident engagement, I think it's important to go back and think about what it is that we do, right? And so we love this quote about Abraham Maslow about the fact that each person is one person defined by things that matter to her or him. And when we look at the normal course of aging, whether there is a diagnosis of dementia or not, whether there is a cognitive impairment or not, we tend to lose a little bit our ability to stay connected to these. And so us, engagement professional, it is our duty to help these people stay who they are, connected to who they are. And one of the things that Dr. Levy mentioned several times is this big focus on person-centered care, this big focus on knowing who is the person and what defines them. I think that what is also important is to understand what is resident engagement. There's a lot of focus today in the market about staff engagement, organization engagement. But I think that we look at research and we looked at the work, if we look at the work of Dr. Jiska Cohen-Mansfield, she was actually the first researcher to look at non-pharmacological interventions. And she is a well-known expert and came up with this scale of the Cohen-Mansfield agitation scale that we might be using in the memory care setting, in the long-term care setting, and also assisted living. But she defines engagement as helping our residents stay occupied and involved with a stimulus. And I think that as we look at activities and life enrichment, this is what we do. We help residents stay connected. Now, our task is very difficult. It's challenging in the way that, we know that the residents cannot self-recreate. There aren't many of us when you look at the staff to resident ratio. And unfortunately, in many cases, there isn't much support from the family. There was a study that was done in the nursing home segment where we know that more than 60% of residents aren't visited by their family member. And we might associate the lack of engagement to an overuse of antipsychotics, but there's also an argument to the fact that the more we use antipsychotics, the more engaging our resident is difficult. So where are we now? We know that in the nursing home setting, a CDC report highlighted the fact that a typical resident only gets 11 minutes of engagement a day, which is obviously nowhere near enough. There's a whole lot of not doing much in the nursing home environment, and that is a challenge when you consider people that cannot self-recreate. We also sadly joke about the fact that and we still see that often, the old standard of activities and engagement was the 3 Bs, right? Bingo and Bible and birthdays. So this all bears a question, which is why aren't we doing better as an industry? Not saying that, there's been, as Dr. Levy explained, a lot of improvement, but where are the opportunities that lie in front of us? And I think it's important to go back to the basic and think about what it is that we do in engagement, in resident engagement, right? We, as we said several times now, we want to get to know the residents. We want to plan something based on who they are, right? Myself being French will not be engaged the same way Dr. Levy will be engaged because we are 2 different people. And if we sit at a different cognitive or physical phase in our journey, we might need different types of activities. Obviously, we want to engage the residents and we want to evaluate. The point is that this might seem like one-on-one activities or rec therapy or engagement one-on-one, But a lot of the challenge of our industry today is that each of these buckets operate in a silo, aren't very well supported by technology. And I think there's a lot to be said about how do we meet the needs and support the purpose of every and all of our residents as a process, with the idea that ultimately, using these personal experience, we can think about prescribing resident engagement. We're having a lot of questions in this webinar, some of them about what is the best engagement. And I think that Dr. Levy mentioned the fact that we want more research and more tools to show actually what works. But there is a silver lining out there, and there is a lot of opportunities. And if you look at some of the providers in the market, some providers out there have been able to reduce to zero. Now, as we know, zero is a huge goal, but have been able to reduce from 17%, which was at the time the national average when they started, to zero. And so this is a community in New York. And by all means, there was not one tool, but it was an overall decision. This is what we're going to do. This is how we're going to address it, and so on. Now, what are the best practices and what are the tools out there? I think it's very important that we think about the fact that we're using a lot of papers, right? So first off, a lot of us still use paper to interview our residents, right? So we want to think about how can we move from paper to something else, because once we do that, then the data about each resident, what defines them, can be then analyzed, and based on where they are, we can deliver engagement where on the like very independent residents, we can help them build and maintain cognitive reserve. But as people need staff support, we can think about doing group activities to slow the decline, engage people, increase social engagement. And at the later stage of aging or dementia, provide these very needed room visits or one-on-one, and sometimes helping people through different types of behaviors. You know, the diversity and needs and preferences of our residents are almost endless. It could range from group program geared towards arts for people that travel to Europe or to France or just like arts. It could be a thing about people just reminiscing about old movies or, you know, for example, John Wayne movies and so on. It could also be just, we have a lot of residents that worked in the advertising industry, so why not reminisce about that, right? And as we go through different phases of aging and cognitive impairment, we all know the power of music for music therapy, which again, to the very late stages of life, can dramatically improve the quality of life of our residents. Now, this is in the delivery and thinking about how we can engage all of these residents with non-pharmacological intervention. One of the things that we see a lot is how the provider, how their staff records what they do. And I think that there's a lot to be said about what we do and what we document and we record. And I know that documentation has a bad reputation, but if we did document and if we did record all of the engagement, whether it would be, you know, group activities or non-pharmacological interventions, we know that some of the best practices, what some of the best providers out there say is that that enables them to then engage residents better and support their staff better. So obviously we have a distinction between an activity staff, a music therapist, a rec therapist. But overall, how do we use our resources to engage people better? On the screen here, this is a CCRC with a large group of independent living, assisted living, and memory care residents. But for example, we see a lot of group settings, like a lot of group activities, right? Now, there are quite a few interventions, non-pharmacological intervention, which is great because we're recording them, which would help us as a team to talk about how we can use non-pharmacological intervention, replicate that, and maybe reduce the use of antipsychotics. But this bears another question, which is, if these non-pharmacological interventions happen at the same time for the same residents, well, maybe we can start thinking about planning a one-on-one at the same time or early in the day to maybe, instead of mitigating, preventing behaviors, right? A good example of this would be, for example, this person here. We know that Lena, for example, responds very well to our programs. She's very active in the program. As you can see, she's been active in groups, which is fantastic. But for some reason, in the past weeks, there has been quite a few non-pharmacological interventions. One, as an engagement professional, I love to see that data, because then that helps me start thinking about, well, Lena likes these programs we do. Maybe changing the timing and focusing on one-on-one could help Lena. And again, if she's under these antipsychotics or these different types of drugs, maybe we can start thinking about removing them or at least reducing the dosage. But one would think also that anyone that engages or talks to Lena might want to know about this information. And think about the family. Wouldn't the family want to have access to this type of information so that we can be proud of how we're caring for their loved one? So again, this can be done with existing tools that we have. It helps blend research and best practices, but ultimately helps us care for our residents in a much more person-centered way, and so on and so on. Technology out there also helps us understand, have we engaged all of our residents? Which are the ones that are potentially, quote unquote, at risk, and so on and so on. And it is exciting, as Dr. Levy mentioned several times, there needs to be more, quote unquote, proof, like proof in the pudding, but research around non-pharmacological intervention. At Link Senior, I just want to talk about technology in general, but say that we do have a clinical research underway where preliminary results show that technology can actually increase social engagement, reduce cognitive decline, and reduce physical and verbal aggression, and actually also reduce medication. So this is very exciting. Again, there's a lot of technologies out there, but the point is that ultimately these results will help us as an engagement industry to show the type of work we do, why we need to do more, and why we need tools to be able to do more. So all of that, kind of leads us to the third section of our presentation, which are, what are the best practices? Like, we are under now 6 months in these new rules of participation. What are the best practices and advice that we have out there? And this section, Dr. Levy and I will tag team, and I will let her kind of start, quote unquote, from the start, which is, what is person-centered care?
Yeah, and so to recap, and Charles, I hope everyone, I think the information you presented really was excellent, and I also do want to comment, so I don't forget, is that today what really we need to derive a lot of our decisions, as we know in healthcare, is data, and I think what you're able to provide us with, both at an individual patient level as well as at a facility level or unit level, is data which can really help make us drive decision making and see what is working and what is not working. And I think that is really key, because so many times we start initiatives just because we think they're going to work, and we don't necessarily find good ways to measure along the way what we're doing and the benefits. So I think that the information you provided is really critical. And I think as a practitioner, that's what I want to see. I want to see that, as I'm increasing a resident's engagement, that we are indeed seeing changes perhaps in behaviors that then allow me to see what I'm doing to replace medications that were previously prescribed and have a much more therapeutic intervention and show how it's been effective. So I think really, every time I see this from you, that the potential power of being able to track that is so important, and how we're trying to change the way we care for all of our residents, make it more patient-centered, and then certainly just focus on our residents with dementia. So anyway, so patient-centered care. What is person-centered care, actually? because we are talking about moving away from the term patient to the person. But the basis of person-centered care, and particularly in those with dementia, did come out of Tom Kitwood's work and his work on personhood and the psychological needs of those who do live with dementia. And so I think that is, certainly very important for us to focus on. It's really, I think the cornerstone of what what actually has been occurring in the engagement field. So, Charles, any comments?
No, for me, what's important is that everyone is talking about person-centered care, and all of our organizations have started placing that as one of the drivers for quality. So I think it's kind of this uniting factor between, you as a medical doctor and practitioner, us often in the engagement or, whether it's activities, life enrichment or rec therapy, but we're kind of all working in the same direction. So this overall framework is fantastic so that we have common ground to work together with.
Do you want me to, is this,
Yeah.
basically for me to summarize? So we're thinking about it. What are the things that we need to be doing? We talked a little bit about the care planning process, how we really need to make sure that truly is person-centered. We really need to understand what it's like for a resident, what it's like in their day, and we need to make sure that their families appreciate what's going on in their day. We should be looking at how we're writing our care plans, and I'm always pleased when I look at charts in various facilities to see how many of them have engaged, truly making their care plans person-centered and using individual language. And think about, I think that's important, thinking beyond what's required. And I always remember people telling us, the regulations are a minimum standard. We can do better. And really think about how do you get your practitioners excited about some of the things that you're doing, and the change that you're trying to affect in your facilities, so that they can certainly partner with you in this journey on more and more person-centered care. And are you all truly working together? Are you working in silos in your facility to really make sure that residents reach their highest practical level of function? Next slide. So there's a lot available out there. We're not going to go over everything or provide copies for everything, but a variety of resources out there. Certainly, often NCAL have a lot of resources on their website. Your state affiliates do. Many of your vendors also have resources for you. Peers, you can teach each other, and certainly CMS through the National Nursing Home Quality Initiative has lots of resources certainly on their website, and also provides webinars. So some of the other things that we're seeing, in terms of focus at the time both of survey and what we're all doing, is really surveyors wanting to see how you are truly individualizing care. And some of the other things that we're beginning to see, particularly related to dementia, and this has a little bit to do with the partnership, is some concerns that have risen about not accurately diagnosing patients with major mental health disorders in efforts to, if you will, play the quality measures game and create exclusions by labeling patients with schizophrenia who may not actually meet criteria. So those are some of the things that we're actually seeing occurring out there in the country.
Thank you very much, Dr. Levy. One quick comment is that we do have AHCA as a resource out there, but obviously Leading Age, Argentum, there are many other organizations out there doing excellent work. I think that one of the things that we keep on mentioning is the fact that we want to drive person-centered care. One of the most fantastic frameworks to do so is what are the questions that we want to ask so far? So, like Dr. Levy, these were just prompted questions you and I had talked about.
Right.
Would you mind going over these? And for example, what do you know of the new survey so far? Like, what is the biggest either surprise for you, one thing that you've learned about the new survey so far?
Well, I think, unfortunately, in most facilities, we also had federal surveyors, or 10, so it was longer. But that's because it's a new process for the surveyors. So there's some differences in how they're coming in and the technical aspects of the survey. But I think a lot of this is really their focus on observations. Lots of time walking around the facilities. Some surveyors always did that. Some surveys always included that more than others. Certainly a lot of focus on looking at choice and individualization. And I think many people seeing some, if you will, citations around those types of issues. But certainly would be curious if in the chat box we have any of our attendees, if they have any experiences that they've seen in the new survey process that they would like to share. We'd like to share that with the group. So
absolutely.
Right away.
Yeah, and we'll keep that for in a couple of minutes. Let's go to the second question we had here. What are the 3 items that you would pay more attention in the way the survey is being done, like when you with the buildings or the communities or the staff that you work with?
I think one of the big things, which I think is always the case, is really making sure you're looking at your care plans and making sure they're individualized, current, and update. I know that's always been a struggle for facilities, but I think even more so there's a focus there. And again, I think really looking at what you're doing regarding providing choice for residents whenever possible. And I think that certainly is also key. I think also making sure that your staff are aware of what your quality initiatives are and can speak to those if there are questions from surveyors, and that it's pretty clear that they're knowledgeable about what's being done in the facility.
Thank you so much. And the third and last question of this slide is, I know that we're so focused sometimes on the survey and the fact that it's disruptive in our work and some people complain about it, but to you, what has improved in that survey? And as a frontline staff or somebody working like an activity director, what should I rejoice about when you consider the new survey process?
Well, I think there is an effort, and everything does take time to really make sure that we're all on the same survey process across the country. There's always going to be, because there's still a people component to it, there's always going to be some variability, but I think there really has been an effort to try to level the playing field. So I think that is, that's important to have, less open for good things open for interpretation, but not everything open for interpretation. So I think that certainly is a positive. And I think really, the education of surveyors should really be able to look for this individualization of treatment plans, of management plans, of care plans, and how care is being provided, and not just in writing, but to actually see it as they are in the facilities, what they're really witnessing, and how to translate what they're seeing and hearing in the facilities, and interpret that in light of the regulations.
Great. Well, thank you so much, Dr. Levy. Given the time, I suggest that we can skip quickly the last slides. We do want to mention the fact that we have this big initiative called All People Are Cool, with a website called allpeopleare.cool. If you want to go there and come and participate in the discussion, you're more than welcome to. And all the profits from the store go to the Alzheimer's Association. But what I suggest is maybe for the last couple, 2-3 minutes, is maybe answer any questions the audience might have. And if you have a question, feel free to use the chat function of the program, and we'll probably pick 1 or 2, and so on and so on. So we have one question here is, Dr. Levy, we know that, as you said several times, there lacks enough research to figure out what are the most effective non-pharmacological interventions. But if you had to pick 1 or 2, maybe 3 to really focus on, what would you tell your activity directors to do?
Well, I think probably the most studied at this point is really focusing on the music intervention. mainly because that's been focused, it's exciting, and I think music speaks to all of us. So I think, but what is key is understanding is how those programs work. Really, it's not just any music. It certainly is music that's individualized for the person. And so it also then meets that person, if you will, person-centered type approach. And the other thing that I keep trying to tell my facilities, these are things that need to be available. All of our staff need to know how to use them. So we need to make sure that if it requires resources, that that's available, 24/7 to staff, to family, to whoever feels that they may need to be able to access some of these tools, to be able to do that at any time that they feel that they have to spend with the resident, or time that they feel that it may be good to have intervention to be able to help them avoid a behavior, if you will, escalating. I think that certainly is one. There is some literature on aromatherapy. Again, I think the point is, to me, is that you really need to understand the resident. You really need to get that information from both the resident and or the family. You need to spend a lot of time on that and updating that, and then using your creativity to be able to see what you think will speak to that individual, and still reach them in whatever stage of dementia they're at.
Thank you so much, Dr. Levy. As you said several times, let's start with the residents, so we need to know who they are and what defines and what their preference is. And obviously what we heard you talk a lot about is how do we make it a team effort. Again, Dr. Levy, thank you very much for joining us today. The audience, thank you very much for taking the time to listen to us today. There's been a lot of questions. Feel free to reach out to us by email afterwards. We do want to highlight the fact that these types of webinars are hosted by Link Senior on a monthly basis, and we invite you in the coming month with an S to join us and be part of that conversation of how we learn about the best practices in resident engagement and how can we improve the care that we're providing to our residents and lead person-centered care. As you can see, the only month where we're not providing these is the month of August because of it's a slow month for most people out there. But then again, we start again in September, and we'll be hosting that on a monthly basis. So this is, and quick focus on the next one. Dr. Galini Majorov is actually at UMBC, and she will be talking about an exciting topic, which is digitizing engagement. She's done a lot of work actually with tools such as Alexa and understanding how technology can help us drive better quality of life for the older adults and our residents. As for the webinar, the survey link and the CEUs, I will take this page here and place it in the chat function for everyone to be able to take that. When we will stop the webinar, a survey, the same survey will pop up. And again, if you need CEUs, you have to fill in the whole survey. If there are multiple people in the room in front of the computer, each person needs to take it once. With that, Dr. Levy, thank you again for your time today and your very valuable information. Thank you for the audience for joining us, and see you next month.